to minimize the importance of beta cell failure. And I'm going to take you starting at the whole body level, and I'm going to take you down to the organ level, and then I'm going to take you down to the cellular level and eventually to the molecular level. And I'm going to review for you the pathophysiology of insulin resistance. And then I'm going to show you how understanding what causes insulin resistance at the molecular level is very strongly attached to the development of atherosclerotic cardiovascular disease. And then I'm going to talk a little bit about an old friend of mine, pioglitazone, because this really is the only true insulin sensitizing drug. And with the recent publication of the IRIS study, I still think there's a very important role for this TZD in the treatment of people with type 2 diabetes. So let's first start by reviewing how the body normally disposes of a glucose load. So you ingest a glucose load, it's absorbed through the gastrointestinal tract. The pancreas can sense the rise in glucose, and it does two things. Insulin level goes up, and then by local paracrine factors, the hyperinsulinemia shuts down glucagon. Now, the increase in insulin and decrease in glucagon lead to a decrease in hepatic glucose production, and the decrease in hepatic glucose production is critically important because when you ingest a glucose load, you can't have two inputs of glucose coming into the body. So when glucose is coming in from the gastrointestinal tract, it's very important that we shut down glucose production from the liver. Now, this increase in insulin concentration, I think everybody's familiar with this, leads to an increase in glucose uptake in muscle. But we also know that the hyperinsulinemia plays a very, very important role in adipocyte metabolism. So it stimulates glucose uptake. But remember, it's only about 5 to 10% of the glucose load that's going into the adipocyte. The majority of an oral load is going in to the muscle in the liver. And this is not to say that the adipocyte is not important, because it's important in a very, very different way. So the hyperinsulinemia shuts down lipolysis, and the plasma FFA concentration declines. And to the right, you can see that decrease in plasma FFA plays a very, very important role in stimulating glucose uptake. We showed this many, many years ago. Richard Bergman showed it, Stephen Kahn. So this is a very reproducible finding. And then to the left, you can see that the decrease in plasma FFA concentration also is playing a very, very important role in the decrease in hepatic glucose production. And these are studies that Dr. Amalia Gastadelli and I published a number of years ago. And then what's less well appreciated is the effect of insulin on the vasculature. So hyperinsulinemia stimulates nitric oxide synthase, and this leads to an increase in nitric oxide. And of course, I think everybody is aware that nitric oxide is the most potent vasodilator in the human body. It's an incredibly potent anti-atherogenic molecule. So the ability of insulin to work on the smooth muscle cell and to increase nitric oxide is going to play a very, very important role in the protection against atherosclerotic cardiovascular disease. And then something that people may be less familiar with is that there are insulin receptors on the beta cell, and I'll come back to this later. If you knock out the insulin receptor on the beta cell, you actually markedly impair insulin secretion. So insulin resistance at the level of the beta cell also plays a very important role in the regulation of insulin secretion. So this very complex system is very well integrated. If all of these phenomena occur simultaneously, you maintain normal glucose tolerance. But what goes wrong in the insulin-resistant person, the person with type 2 diabetes or the overweight, obese person? So let's start here at the gastrointestinal tract. We know that in newly diagnosed diabetics, there's actually an increase in the rate of glucose absorption. And here comes the signal to the pancreas to release insulin. But unfortunately, the increase in insulin is impaired in people with type 2 diabetes. And that results in a decrease in the ability of insulin to knock down the plasma glucagon level. We also know that there's severe insulin resistance at the level of the liver, and I'm going to take you through all of these steps in more detail. So the insulin resistance at the level of the liver, in combination with insulinopenia and with a hyperglucagonemia, leads to a stimulation of hepatic glucose production. This leads to an increase in the fasting glucose and impaired suppression of hepatic glucose after a meal. I think everybody who's listening in is very aware of the fact that the ability of insulin to stimulate muscle glucose uptake is severely impaired. And I'm going to take you through the biochemical, cellular, and molecular etiology of this insulin resistance in a few moments. At the level of the adipocyte, the ability of insulin to stimulate glucose uptake is impaired. But more importantly, the ability of insulin to inhibit lipolysis and decrease the plasma FFA concentration is impaired. So in the upper right, the plasma FFA concentration fails to decrease normally, and this contributes to the insulin resistance in the muscle. And then in the upper left, the inability of insulin to suppress the plasma FFA leads to a stimulation of hepatic glucose production. Now, what about the implications for atherosclerosis? Now, because insulin is working through the same insulin signaling pathway in muscle and smooth muscle, we fail to generate and activate nitric oxide synthase, and therefore we don't generate nitric oxide. And on a long-term basis, this is going to contribute to the development of atherosclerosis. And then at the level of the beta cell, there is an inability of insulin to activate the insulin receptor. And so if you were to count these X's up, you would see that there are 8 of them. And this is the ominous octet for insulin resistance, very similar to the ominous octet for the whole body pathophysiology of type 2 diabetes. So now let's start at the whole body level. So many, many years ago, we developed a technique called the euglycemic insulin clamp to measure whole body insulin sensitivity. And on the y-axis here, I've plotted glucose uptake. The units are milligram per meter squared per minute. But what's important is just to look at the heights of the bar. The healthy, control, normal glucose tolerant individuals are shown in yellow. In response to an increase in the plasma insulin of about 100 microunits per ml, they take up and metabolize about 250 milligram per meter squared per minute. Now, if you look at the green bars, these are normal weight type 2 diabetics. You can see they have about a 50% reduction in whole body insulin-mediated glucose metabolism. And then to the right in blue are the obese non-diabetics. And you can see that obese non-diabetics on mean are as insulin resistant as the normal weight type 2 diabetics. And the implication here should be pretty obvious. If you are a normal weight type 2 diabetic who is very, very insulin resistant, your beta cell is already being stressed trying to pour out enough insulin. You now gain weight, and now you superimpose the insulin resistance of obesity on the insulin resistance of type 2 diabetes. Your beta cells are not going to be able to handle this. And the stress on the beta cell promotes premature beta cell failure and apoptosis. So clearly at the whole body level, there's severe insulin resistance. Now, many, many years ago, we asked, what are the tissues that are responsible for this insulin resistance? So when I was on a sabbatical in Sweden with Professor John Warren, Dr. Ellie Ferranini and I did a number of studies where we put catheters into the femoral artery and the femoral vein, a catheter into the renal vein, hepatic vein, in the jugular vein. And so we could really look at where the glucose was going and what was the tissue that was primarily responsible for this defect in whole body insulin-mediated glucose uptake. And you can see here, it's the muscle tissue, which is primarily responsible for this insulin resistance. So on the x-axis, I plotted time, and on the y-axis, leg glucose uptake. The control subjects are shown in yellow. you can see within 20 minutes, there's a very rapid uptake in glucose into the muscle. At 60 minutes, we reach a plateau. Now, a very different picture is seen in the diabetics. When you infuse the insulin during the euglycemic insulin clamp and you're measuring leg glucose uptake, really nothing happens for the first 40 minutes. Now, eventually, you start to stimulate glucose uptake, but even if you carry out this study for an extra 60 minutes to account for this lag in the onset of insulin action, you can see that there's about a 50% decrease in leg muscle glucose uptake. And this is accounting for the great majority of the whole body defect in terms of insulin-mediated glucose uptake. So let's now start to take a deeper look within the muscle as to what are the pathways that are involved in this insulin resistance. In order for glucose to get into the cell, insulin, of course, has to stimulate the GLUT4 transporter. Glucose gets into the cell, needs to be phosphorylated by hexokinase 2. And then there are two major pathways to which the glucose is going to go. To the left is the glycogen synthetic pathway, and about 2/3 of the glucose goes into glycogen. And to the right is the glucose oxidation pathway, and about 1/3 of the glucose is going to be oxidized to generate ATP. Now, the two rate-limiting enzymes are shown for the glycogen synthetic pathway, it's glycogen synthase, and for the glucose oxidative pathway, it's pyruvate dehydrogenase. So, where is the intracellular defect? So this is a study that Dr. Jerry Schulman and I carried out many years ago when we were at Yale using C13 NMR, where we're going to perform a euglycemic insulin clamp, and then we're going to measure the rate of glycogen synthesis. The control subjects are shown in yellow, and you can see that there's really a quite steep linear rise in the incorporation of C13 glucose into glycogen in muscle. In contrast, in the type 2 diabetics are shown here in orange, you can see there's about a 50% decrease in the incorporation of glucose into glycogen. So from sort of the whole muscle level, there's clearly a huge defect in muscle glycogen synthesis. So when Dr. Larry Mandarino was a faculty member here at the University of Texas, we carried out studies where we did muscle biopsies in people with type 2 diabetes, and we measured glycogen synthase activity in healthy control subjects, orange, and in type 2 diabetics in yellow. Now, the height of the bar represents the total amount of glycogen synthase, and then the dark part of the bar represents the amount of active glycogen synthase. And I think it's very clear that in the type 2 diabetics, the total amount of glycogen synthase is decreased, and almost all of this is accounted for by a decrease in the active form of glycogen synthase. And this, of course, explains the major defect in glycogen synthesis during the insulin clamp. Now, what about pyruvate dehydrogenase? This is shown to the right. And again, the control subjects are in orange, the diabetics are in yellow. Again, the height of the bar is the total amount of pyruvate dehydrogenase, and the dark portion of the bar is the active part. And you can see that there's both a decrease in the total as well as the active part of PDH. So there's also a defect in glucose oxidation in the muscle. But from the quantitative standpoint, the major defect is in the ability of insulin to stimulate muscle glucose uptake. So let's come back now to this muscle cell. So long before glucose gets into the oxidative and glycogen synthetic pathway, it has to get into the cell through GLUT4, and then it has to be phosphorylated by hexokinase 2. So what do we know about GLUT4 and hexokinase 2? So at the time that we were doing these studies, Dr. Tim Garvey had developed a technique to measure GLUT4 transporter protein and mRNA. Protein is shown to the left, the mRNA to the right. And you can see in response to insulin, as well as in the basal state, the amount of GLUT4 that's present in the diabetics in orange is no different than in the control subjects. So in terms of the muscle, we cannot explain the insulin resistance by a decrease in GLUT4. So what we were interested in was what would happen. Of course, these are in vitro studies. What would happen if you measured glucose transport in vivo? And at this time, I had a very bright young fellow who's with me, Dr. Riccardo Bonadonna, who's now a full professor back in Italy. And he developed a very sophisticated triple tracer technique to measure glucose uptake in the forearm muscle. So to the right, we're going to take these three traces and we're going to inject them into the brachial artery. And then from a deep vein, we're going to collect the traces as they emanate. So what are the three traces? The first one is C12 mannitol. Why C12 mannitol? This behaves just like glucose, so it gets into the bloodstream, it diffuses into the interstitial fluid, but it's not going to get into the cell. The second tracer is C14-O-methylglucose. This does what mannitol does, but it will also enter into the cell. So in the deep vein, we're going to get back a little bit less of the C14-methylglucose than the mannitol. And then the third tracer is tritiated glucose. And it does everything that 3-O-methylglucose does, but in addition, it gets metabolized. So it's actually providing us a measure with phosphorylation. So you can take these washout curves and you can model them, and you can come up with rates of flux into the cell. And you can see that transport into the cell in the people with type 2 diabetes is markedly reduced. And then to the right, you can see that phosphorylation is almost obliterated. And it's obvious that the defect in phosphorylation, this is hexokinase 2, is much greater than the defect in glucose transport. So there are defects in both glucose transport and phosphorylation. And as I said earlier, they have nothing to do with the amount of GLUT4. They have to do with the inability of insulin to activate the GLUT4 transporter and also to activate hexokinase 2. And we show that and by taking these subjects back and then infusing insulin and then measuring hexokinase 2 activity. So it turns out that hexokinase 2 is one of the enzymes that's acutely regulated by insulin. It's activated in 2 to 3 hours, and you actually can show in normal people an increase in the activity, as shown in this slide, as well as what you're going to see in a moment, an increase in the HK2 protein amount in mRNA. But clearly, you can see that hexokinase 2 activity in people with type 2 diabetes is severely impaired, consistent with our in vivo measurements of flux through hexokinase 2. Now, what about the increment in hexokinase 2 mRNA? Again, severely impaired in the type 2 diabetics in orange. And then here is the protein. So these data really, I think, are really quite consistent. Yes, there's a defect in GLUT4. Yes, it's quite severe, but there's an even greater defect in hexokinase 2. So now we need to come and take it a step earlier, because even before we activate GLUT4 transport into the cell and activate hexokinase 2 to stimulate phosphorylation, we need to activate the insulin signaling pathway. So how does this pathway work? So insulin in the upper left must first bind to its receptor. There are 3 tyrosine molecules that need to be activated. If you phosphorylate these 3 tyrosine molecules, it will send a message to the GLUT4 transporter. So how does this message get generated? So within the cell, there's a molecule called insulin receptor substrate 1. And when you activate and tyrosine phosphorylate the insulin receptor, IRS1 moves to the plasma membrane. It gets phosphorylated and the same 3 tyrosine molecules. This then activates PI3 kinase, AKT. There are a number of other steps which I haven't included. Now, if this system all works well, glucose gets transported into the cell, and we're going to stimulate glucose metabolism. But equally important, what people have forgotten, and I emphasized this earlier in the very first slide in this presentation, is insulin activates nitric oxide synthase, and this increases nitric oxide, and this is essential in terms of preventing the development of premature atherosclerosis. And as I said, if this system works well, you take up glucose, metabolize it normally, and you maintain normal glucose tolerance. Now, there's another part of this pathway that people have forgotten about, but I'm going to come back to that in a second. So what goes wrong in the person with type 2 diabetes? The ability of insulin to bind to the receptor and tyrosine phosphorylate the receptor is intact. However, the next step, starting with IRS1, is severely impaired. So there's a major defect in this signaling pathway. And then what happens? Of course, GLUT4 transport of glucose into the cell is impaired. What is the result of this? Prediabetes and then diabetes. And then what happens to nitric oxide synthetase? Well, you impair that. Nitric oxide generation is impaired. And this is going to lead to premature atherosclerosis. Now, again, if you think back to what I said at the beginning, the insulin resistance is present very early in the natural history of the disease. So individuals who are destined to develop diabetes or who are insulin resistant, these people are going to develop premature atherosclerosis. They're sitting in a sea of atherogenesis, probably from day one of their life. Now, here's that other pathway that I mentioned earlier. So everything that IGF-1 does, insulin does. So insulin is a potent growth promoting factor. So insulin, when it binds to its receptor, activates the MAP kinase pathway. This is the mitogen activated protein kinase pathway. Now, it can activate that pathway through IRS1, but that doesn't work in the people with type 2 diabetes. But there's an alternate way through a molecule called SHIC. And this pathway is completely open in diabetics. So even though the glucose metabolic pathway and the NO pathway are impaired, this pathway is wide open. Now, what's the problem? This is the pathway that causes inflammation in cells, vascular smooth muscle cells. This is the pathway that causes vascular smooth muscle cell growth and proliferation. This is the pathway that causes premature atherosclerosis. So let's take a look at the top. You have a defect and you cannot get glucose through the GLUT4 molecule. So the plasma glucose concentration goes up. Now, early in the natural history, pre-diabetes and in early onset diabetes, these people are actually hyperinsulinemic. Now that insulin, what is it going to do? It's going to bind to the insulin receptor. It wants to drive the insulin signaling pathway, but it can't. So what does it do? It drives that MAP kinase pathway. And so now you get hyperstimulation of the atherogenic pathway. And that is why atherogenesis and glucose intolerance diabetes go hand in hand. And that's why a quarter of people who present with type 2 diabetes also have clinically manifest atherosclerotic cardiovascular disease. So to test this hypothesis further, in San Antonio, what we did is we looked in families where both parents had type 2 diabetes. And then we looked for children in these families, and that was easy to find the children. What was difficult was to find lean children, but we found them. And then we did a euglycemic insulin clamp. So remember, these are young kids, okay? But they're destined to develop diabetes because both parents have the disease. They have perfectly normal glucose tolerance. So we do the insulin clamp and we measure tyrosine phosphorylation of the insulin receptor. Those are the first two bars. You can see in the people with family history positive, there's increased tyrosine phosphorylation of the insulin receptor. Why? They're hyperinsulinemic and we've overactivated this receptor. Now in the middle, what about the IRS1 pathway? Severely impaired PI3 kinase impaired. These people basically have the same defect as their parents, but they're just kids, okay? Now, here is the worrisome part of the story. So what about ERK activity? This is a key molecule in the MAP kinase pathway, and ERK phosphorylation. They are markedly overstimulated. So as I said earlier, these kids are sitting in a sea of really premature atherogenesis at the molecular level. Now, if you measure their triglycerides, they're in the normal range, but they're in the higher normal range, and certainly higher than the kids who have no family history of diabetes. Their blood pressure, same thing, in the normal range, but in the high normal range. You measure their HDL cholesterol, it's a little bit on the low side. So these kids are sitting in a sea of molecular and also cardiovascular risk factors that are going to promote atherogenesis. Now, let's turn to the liver, because we know from studies that we've carried out that the liver is also resistant to insulin. So these are studies we carried out many years ago using tritiated glucose, and these are actually the first time that any radioisotope was used to trace metabolism in humans. And you can see in the people with type 2 diabetes, people go to sleep at night, we wake up in the morning, and we measure their basal rate of hepatic glucose production, it's significantly increased. It's about 2.5 versus 2.0. Now, you look at this and you say, oh, that's not a big difference, 0.5. But look at the units. It's 0.5 milligram per kilogram body weight per minute. So 0.5 times, say, a 90 kilogram person times 1,440 minutes during the day. The diabetic is dumping an extra 50 or 60 grams of glucose into the systemic circulation every day of his or her life. And this is what's responsible for the increase in fasting glucose when they wake up in the morning. And that's demonstrated very clearly here. So on the x-axis is the fasting glucose. On the y-axis is the rate of hepatic glucose production. The control subjects all cluster with a fasting glucose of 90 and a basal rate of hepatic glucose production 1.8 to 2. The orange dots are the diabetics, and you can see as the rate of hepatic glucose production, so goes up the fasting glucose, and the correlation coefficient here is incredibly strong. It's 0.85. So the major cause of fasting hyperglycemia is this excess production of glucose by the liver. Well, what happens when you infuse insulin? Can we shut down hepatic glucose production normally? So this is a dose response study that Leif Group did when he was with me many years ago in New Haven. And in this, you can see by the individual dots, we raised the portal insulin concentration by about 15, and then about 30, 40, 75, et cetera, microunits per ml. And you can see in the diabetics, which are the orange curve, that the curve is clearly shifted to the right. For any given insulin concentration within the physiologic range, there's an impaired suppression of hepatic glucose production. At very high insulin concentrations to the right, you can overcome this insulin resistance, but these are really at quite pharmacologic levels of insulin. Let's now turn to the adipocyte, because as I showed you in the earlier slide, the adipocyte is also resistant to insulin. Now, these are, again, studies by Dr. Tim Garvey. And again, you're going to see something very different in the adipocyte than in muscle. So Dr. Garvey did fat biopsies, and then he did this in control subjects in yellow, obese subjects green, diabetics in orange. And then he stimulated the fat with insulin and looked at glucose uptake. And you can see that both the obese and the diabetics, green and orange respectively, there's a decrease in glucose uptake in response to insulin. Now, unlike muscle, you can see that there's a decrease in GLUT4 protein in mRNA. So what this is saying is that there's tissue-specific regulation of GLUT4 expression. So a very different response in the adipocyte than in the muscle. So here, clearly GLUT4 is impaired and contributing to the insulin resistance. Now, what we were more interested in is what happens to the plasma FFA concentration. So remember, FFA are stored as triglycerides. When you infuse insulin, you inhibit lipolysis and the plasma FFA concentration declines. So this is a dose response curve showing the control subjects in yellow and the diabetics in orange. And you can see that for any given increment in the plasma insulin concentration, there's impaired suppression of plasma FFA. And we also carried out these studies with C14 palmitate. And you can see in the diabetics that the palmitate turnover parallels the FFA level. So the ability of insulin to inhibit lipolysis in the fat cell is severely impaired. And as Dr. Garvey showed, the ability of insulin to stimulate glucose uptake into the fat cell is also impaired. So how do free fatty acids cause insulin resistance? So that increase in FFA, the plasma of FFA is going to move into the muscle, and it's get hooked to acetyl to a CoA derivative. So fatty acyl CoAs stimulate serine kinases. So why is that important? Serine kinases cause serine phosphorylation of IRS1, and when that happens, you inactivate IRS1. Fatty acyl CoAs lead to an increase in diacylglycerol. That leads to a stimulation of some of the ectopic forms of PKC, which also cause serine phosphorylation. And so we're going to markedly impair the insulin signaling pathway. Now, the smooth muscle cells also are very resistant to insulin. And these are some beautiful studies carried out by Gene Barrett, who was a fellow with me many years ago. But what Gene did is he developed a microbubble technique where he's going to inject into the brachial artery. He's going to inject these microbubbles, and then with ultrasound, he can see where the bubbles are going. Now, at rest, it turns out, as shown at this slide, only one of the 3 capillaries in the muscle is open. So now, when Dr. Barrett infused insulin into the brachial artery, look what happened. The other 2 capillary beds that were closed down are now open. So insulin is actually a very powerful dilator. Now, what happens when you do this study in people with type 2 diabetes? And again, this is Dr. Barrett's work. You can see that the ability of insulin to recruit those other capillary beds is markedly impaired. So there's vascular smooth muscle resistance in terms of generating nitric oxide. There's also vascular smooth muscle resistance in terms of opening these capillary beds. That's going to be less perfusion of the muscle, which is going to contribute further to the insulin resistance. So what we have now is an ominous octet for muscle insulin resistance. Insulin receptor signaling doesn't work. The glucose transport system doesn't work. The ability to activate hexokinase and phosphorylate glucose is impaired. Glycogen synthase doesn't work. PDH doesn't work. And I haven't discussed the mitochondrial dysfunction and inflammation because of time, but there are these other multiple defects as well. Now, I also told you that there's insulin resistance at the level of the beta cell. So the next data set, these are from the Ron Kahn lab at the Joslin Clinic. And this is the Burkout knockout mouse. So we're going to knock out the insulin receptor on the beta cell. And now when you do that, if you look at the left-hand panel and we administer a glucose load, you can see that the animals become severely hyperglycemic. Now, why do they become severely hyperglycemic? Well, if you look to the right, there's a severe defect in insulin secretion. So the intactness of the insulin receptor on the beta cell plays a very, very important role in the ability of the beta cell to respond to glucose. So this is insulin resistance at the level of the beta cell contributing to the insulin secretory defect. And then I think everybody is familiar with the metabolic syndrome. And for those of you who know me, I don't call it the metabolic syndrome. I call it the insulin resistance syndrome, because this is really what it is. So if you go down this list, and I'm going to do it very quickly, every one of the abnormalities or clinical phenotypes on this list is associated with insulin resistance, obesity. Everybody knows this, particularly visceral obesity, diabetes, IGT. Many years ago, Ellie Farinini, when he was a fellow, did this classic study showing that people with essential hypertension were severely resistant to insulin. These are normal glucose tolerant people. We and many others showed the dyslipidemia, again, an insulin resistant state. Insulin resistance associated with high plasminogen activator inhibitor 1 levels, endothelial dysfunction. We now know that NASH and NAFLD is the metabolic manifestation of insulin resistance. And ultimately, since each of these is an individual risk factor for cardiovascular disease, we're going to get a lot of cardiovascular disease. And as I showed you, the actual molecular etiology of the insulin resistance is independently contributing to the cardiovascular disease. So now, as we were publishing these data, and what we did is systematically take every one of these phenotypes and we performed insulin clamps in them. And so the rate of glucose uptake in response to insulin is shown on the y-axis. The control subjects are sort of the standard that we're going to compare against as we go across. They're in yellow. Lean type 2 diabetics, obese, normal glucose tolerant individuals, severely insulin resistant, people with essential hypertension, hypertriglyceridemia, and then studies in which we looked at people with at least 2 coronary arteries with greater than 50% stenosis compared to individuals who came to cardiac cath and were found to have normal coronary arteries, severely insulin resistant. So all of these very diverse clinical phenotypes are characterized by insulin resistance, and they're all major risk factors for cardiovascular disease. Now, as this story was starting to unfold, a number of people made a measure of insulin resistance. Some people did it with HOMA, some did it with the Matsuda index. It really didn't make any difference. And then they followed these people up over long periods of time. And what all of these studies showed was that both insulin resistance independently, as well as the insulin resistance syndrome or the metabolic syndrome, predicted many years later, 5 to 10 years later, the development of cardiovascular disease. So the Botnia study in Sweden, Dr. Group's study, the Verona study, Enzo Bonura's study in Verona, Italy. Everybody knows the Framingham study. Dr. Michael Stern and Steve Hafner, the San Antonio Heart Study, the Brunick study, the Malmo study, the ARIC study. I can go on and on and on. Every one of these studies showed that insulin resistance predicted cardiovascular events. Now, I still am a big advocate of pioglitazone. I still use it as part of my triple therapy in all type 2 diabetic patients. It is the only true insulin sensitizing drug that's going to reverse the insulin resistance and, in fact, impacts favorably in every one of the components of the insulin resistance syndrome. Now, what is the evidence that pioglitazone reduces cardiovascular events? So this is the PROACTIVE study, 5,238 patients carried out in Europe, in which they took people who had a cardiovascular event, and then they looked at time, this is Kaplan-Meier plot to time, to the MACE endpoint, which is cardiovascular death, non-fatal MI, non-fatal stroke. Hazard ratio is 0.84. There's a 16% decrease in cardiovascular events. Now, this is highly statistically significant. Now, to the right, at this time, Takeda Pharmaceuticals was carrying out studies in the US to get pioglitazone approved by the FDA. So this slide actually comes from the FDA website, and it's an analysis done by the FDA on every study carried out with pioglitazone in the United States, submitted to them by Takeda. Now, the importance of this meta-analysis is, number one, it was done by the FDA, but more importantly, to get into these studies, you could not have a previous cardiovascular event. So this is primary prevention. Hazard ratio is 0.75. There is no doubt in my mind that pioglitazone is a potent antiatherogenic molecule. Now, if you were in the PROACTIVE study, if you had a stroke, and I put you on pioglitazone, recurrent stroke was decreased by 47%. That's better than anything that you can do, including surgery, okay? So Dr. Silvio Inzucci at Yale was very much aware of these data from ProActive. So he got a quite renowned neurologist, Dr. Kernan, to join him to go to the NIH, and they convinced the NIH to do a long-term study in people who had either a stroke or a TIA. And to get into this study, as I said, you had to have a stroke or TIA within 3 months. But most importantly, you could not be diabetic, okay? So what's plotted on the y-axis? It's the cumulative probability of event-free survival. And here you can see the orange curve, pioglitazone, lies above the yellow curve. Hazard ratio is 0.76. It means there's a 24% decrease in recurrent stroke and cardiovascular events in a non-diabetic population. So this has got nothing to do with lowering the glucose. So how does this happen? So there are a multitude of mechanisms by which pioglitazone prevents atherosclerotic cardiovascular disease. First, we get PPAR activation, and this leads to turning on a whole host of genes that are in the mitochondria and driven by PGC1. We improve insulin resistance in all of the components of the metabolic syndrome. We improve endothelial dysfunction. What does that mean? An increase in nitric oxide. We inhibit inflammation. So C-reactive protein goes down. We inhibit the NF-kappa beta, I-kappa beta pathway. We mobilize fat out of arterial wall. This is the best drug for treating NASH and NAFLD. I doubt anything that's going on now is going to beat pioglitazone. We decrease PI1 levels, we reduce blood pressure, and we correct diabetic dyslipidemia. So all of these mechanisms collectively contribute to the anti-atherogenic effects. Now, this is my last slide. One of the people that I looked up to greatly in the diabetes field was Professor Gerald Reaven. And in my opinion, he really is the modern day father of this disease. And when he gave his famous Banting lecture, you can see to the right, he clearly pointed out that pre-diabetics with IGT and people with type 2 diabetes were clearly insulin resistant. And then at this time, he also described for the first time the metabolic syndrome, in which he showed very conclusive evidence that if you had diabetes, obesity, hypertension, dyslipidemia, coronary artery disease, you were insulin resistant. And these disorders were all closely related to the insulin resistance. And he really is the father of the modern day insulin resistant syndrome. A great guy. Last slide, we can open it up to questions.
Thank you, Raul, for a wonderful presentation. And as usual, your extraordinary, outstanding work in insulin resistance. We have quite a few questions here. Pansi, would you like to, somebody, Dr. Jimit Vadgana has asked a question. Do you think pioglitazone has been wrongly projected as a harmful drug, despite of huge cardiovascular, cerebrovascular, beta cell protective effect with so much of evidence you have said? It's a true insulin sensitizer. So why has pioglitazone been sort of devalued? Though, of course, in India, we use a lot of it.
Yeah. So I think a lot of bad sort of press